like us to just get started right away so we can give maximum time to Nicole. I hope you all are well. As you know, we usually start with news and updates. In favor of time, I would like to ask you to use the chat to share your good news with us, but please do use it heavily because we want to hear your good news, publications, presentations, etc. coming up. It would be wonderful to learn about it. In terms of presentation, today we will hear from Dr. Werner about co-design for implementation across the patient and care partner journey. I have heard Dr. Werner talk at a conference last year, and I was so impressed by her work. So I'm very excited to have her here today and share it to this group. We are recording these sessions. I am sure that Kara let you know. So some people might not be able to attend today, but they will have the opportunity to listen to you share your wonderful work as well. Let's go to the next slide. Constant reminder to you all that we are making some developments on the D&I models in Health Web Tool. And specifically right now, we are laser focused on the assess section. We are trying to add additional instruments. So if you know of assessment instruments, qualitative, quantitative, mixed methods that you don't find there, so this is a trick. We get you there so that you look at it. But if you don't see an instrument, we would love you to email us because we are looking for those missing pieces. What are we not including? And so there is a QR code, and Kara will drop this in the chat, I know, as well, to contact and to provide information about your instrument. And hopefully that way, and Nicole, this is also an invite for you that if you know of any instruments in your field that would be relevant in the implementation science context, I don't think we have so many from the usability field. So that would be incredible contribution. Let's go to the next slide.
Borsika, could I just add a 10-second thing to that? We also are going to be at the D&I meeting in mid-December and have a table there to present and show this. If you have a chance there and would like to talk in more detail or whatever, and lovely Kara is going to be there and kind of hold the table down and explain. Borsika and I will rotate in and out. And so we'd love to talk with you in more detail about that if you're going to be at the annual meeting.
Thank you so much, Russ. We usually also share some additional upcoming presentations. This is one from our DISC in STEP and IS Hub seminar series. We will put this in the chat, so let's move on, Kara. And then there is a new opportunity for faculty to apply for UC San Diego, and it's in the area of implementation science and health services research. It is a half-time teaching position with a research position on the other half. If you are interested, there is a QR code there. This is to contribute to teaching in our PhD program, which is newer, and it concentrates in health services research and implementation science. Since it's so relevant, we wanted to make sure you know about it. And we can go to the next slide. And then finally, Kara and the intern team did an incredible job preparing us for the D&I conference. And very soon, we will be sharing with you our manual that includes all the presentations that hit on the keywords of adaptation, fidelity, or tailoring. Kara and I were on the phone Friday to decide what to do because this year it almost doubled the number of abstracts that were meeting this criteria. So we are very excited. So we just kept all of them. First, we looked at it. We were sure that something was wrong, but no, these are very, very much relevant presentations. So very soon we are going to make those available to you. And then next in November, we can talk a little bit about, how to approach strategically as a group, going to these presentations and perhaps inviting some of the presenters to come and present in this group as well. So we can, and then here's the call out for the table. Next month, we are going to hear from Dr. Erin Kenzie, talking about causal loop diagrams and adaptations. Very exciting. And it has been moved to November 17 due to Veterans Day being the week before. And then December, please do not miss the opportunity to meet with Dr. Ashbrenner, a longtime member of this group. She will be talking about a new paper on measuring the impact of adaptations that came out this year. And then January, we are going to do our usual recap from the DNI conference, so bring your ideas. And February, we are already booked with Monica Perez-Yales, talking about the new functions and forms repository. We are looking for nominations for additional presentations for 2026, so please use the QR code that Kara will also drop in the chat to self-nominate or nominate others. Moving on, I think we are at the moment that I was waiting on. And I will say that I really enjoyed reading Dr. Werner's bio. And I hope I pronounced the last name correctly. This is my mother-in-law's last name. So this is how we pronounce in a German sound, but I don't know if that's how you would pronounce it.
It's been Americanized, but it was German.
Okay, very good. Well, you will
You're
tell us
good.
how you pronounce it, but I definitely was excited to read your bio because there are so many really incredible contributions to the field. I'm going to read part of it and then we will place in the chat the full bio so you get to kind of experience that. But thank you so much for being here. Dr. Werner is a PhD Associate Professor of Anesthesiology and Biomedical Informatics at Vanderbilt University School of Medicine, and the director of the Center for Research Innovation in System Safety in the same institution. Trained in human factors and applied cognitive psychology, she's an interdisciplinary boundary spanner, merging discipline through a human-centered design approach to engage clinicians, patients, and care partners in co-designing interventions that transforms the patient journey in ways that address a range of patient-centered outcomes. She has an incredible amount of funding, including from the National Institutes of Health, the National Science Foundation, the Patient-Centered Outcomes Research Institute, Health Resources and Services Administration, and ARC. And the work is co-produced innovative but realistic health technology and care process interventions to improve the quality and safety of healthcare within and across healthcare settings and then the home, with a particular focus on care partners for people living with dementia and families caring for children with medical complexities. And I will stop there, but we will provide all the additional wonderful details because I want to give you the full time and hopefully a good discussion for this group. And thank you for being here.
Oh my goodness, thank you. And thank you so much for inviting me. I'm thrilled to be here. I'm going to share my slides here and get started. All right, and then let me know if you can't see them. But as was mentioned in the chat, please feel free to put your questions in the chat and I can answer questions as I go. I'm going to be less talking specifically about like my specific research projects today and more talking about the process of co-designing for implementation across the patient and care partner journey. I'll give you some examples from research projects, but not going deep into the specific methods for those, but I'm happy to answer questions about that if that's helpful. See if I can advance. There we go. I'll start off just telling you a little bit about me. As was mentioned, I trained in applied cognitive psychology and human factors. I call it human factors engineering, but my PhD is in human factors and applied cognition, which is in the psychology department. And human factors engineering is an interesting field that kind of combines psychology and engineering. So we end up being in all kinds of departments, but also both psychology and engineering departments. And my first faculty position was in a college of engineering. So I get to be a hybrid of things. But I have this picture on the screen because I just like to kind of center everyone in that this is how I started my work. When I was getting my PhD, I did experiments in the basement of the psychology building where I invited undergraduate psychology students to do this thing, which is to program a VCR, which no one even knew what that meant at that time. But they programmed the VCR, I would interrupt them and I would make them do math problems and then I would measure their performance as they restarted from the interruption. And I was really interested in that cognitive process of resuming from interruptions, which is still very relevant for today, right? Actually is how I got interested in healthcare. Because when I was in grad school, my advisor and I were approached by a hospital system in the DC area where I was. And they were implementing this new thing called computerized physician order entry, which was basically how all prescriptions are written today, which is electronically versus the written and scanned versions that happened back then. And they were really interested in how that was going to change the work in their pharmacy, and in particular, how pharmacists were going to be interrupted by this process. And so that's how I got my start in healthcare. And when I took my learnings from these experiments in the basement of the psychology building and I tried to bring them into healthcare, I realized that there were like a lot of instances where the theoretical aspects of what I had decided about cognitive psychology were not playing out the same way in that healthcare environment. Because people were compensating and they were using strategies and they were doing all these interesting things to their environment to try to support their performance. And that's how I got into this idea of, okay, well, what we really need to do is take this systems approach. And as I got more and more into healthcare, I realized also that kind of my top-down approach of doing experiments and testing things was often not getting at what the real problem was. And so I found myself sometimes designing interventions that people weren't using or that were failing or not being implemented in ways that I had intended. And that's how I got into this idea of co-design. And this is kind of where I am today. Although most of my co-design now is not in person. This is the before times when we used to do co-design only in person. But I realized I really needed to start with the people who were going to be using the thing, implementing the thing, and figuring out, am I solving the right problem? What problems actually need to be solved here? And how is this going to be successful? And so that's just my little story of how I went from computers to people. And so my work has really stayed in that place. And in particular, I'm really interested in, like, from a patient and care partner perspective, that they do work both at home and in formal, quote unquote, formal healthcare environments to manage their health over time. And this work is distributed over time, space, and people. Space being, acute care and more formal healthcare settings like primary care, ambulatory specialty care. At home, a huge amount of health work for patients and families happens in the home, and across people, right? So there's the individual who might be, focused on managing their health or their chronic condition, the care partner or partners who are supporting them, and all the other formal clinicians, community health workers, and others who might be involved in that care. And I've been calling this, and others have been calling this, the patient journey. And my call to action is that the patient journey needs to be transformed. And that I think that the way to do this is by bridging disciplines, bringing many disciplines together so that we can transform the patient journey through co-design. And so that's kind of the basic premise of most of my work. And when I say patient journey, I'm also talking about what happens in the hospital settings. I do a lot of work in that space and in transitions between the hospital and other settings. And so it's not just patient work in the home, but it's patient work throughout that full journey. I want to start off now by talking about what is co-design, because I think this is actually pretty murky for some people. I'm sure many of you kind of have this definition, but I like to start out with it because I think it's really key here. So co-design is designing with, and I often think of there being kind of three key concepts for co-design that need to be there to be able to call it co-design. One of those is democratization. So really the kind of sharing of decisional power among everyone, not just the research team. The second is generativity, right? So this is about co-designers coming together to create and really recognizing the creativity that's inherent in everyone, right? I think sometimes when, and I talk about this with co-designers a lot, is like, we're not all like Picasso. We don't have to be Picasso or, Steve Jobs, or, creativity doesn't have to be that, right? Creativity is really inherent in the way that we live our everyday lives and do our everyday jobs and make that work despite all the things, right? And so creativity is in all of us, and the generativity aspect really honors that piece and tries to bring it forth. And then the third, and maybe the most difficult, is the engagement across the full process of design. So when you're thinking about co-design, it's not just bringing people in to do this one thing, right? It's really about sustaining engagement across the full design process, from problem identification, ideation, evaluation, and iteration. And so if this is all integrated, then the idea is that it increases the chances of the what's created being more usable, useful, relevant, acceptable, and adaptable to diverse needs. And so it's sometimes helpful to know then, like, what is co-design, what is not co-design, right? And so I think I'll just preface this by saying, just because you're not doing co-design doesn't mean you're not doing a rigorous and great research approach, right? There's lots of great approaches out there. Co-design is one that I happen to be very passionate about using, but that doesn't mean others aren't good and should be used. And so I'm not saying that, so I'll preface that. So when researchers define the problem and define the solution, and then bring something to someone for feedback, or bring them a thing to measure performance, or conduct interviews and focus groups to say, why did you use this, or why didn't you use this, and what made it easier and what isn't easier. And so that is not co-design, right? That is not sharing of decisional power. That is not generativity. And that is not necessarily sustained engagement. So just like to kind of couch that, it's okay to do those things and good to do those things in many circumstances, but calling it co-design would not be appropriate in this if we want to use terms that are appropriate to the method. Okay, so then the other question is why? Why do we co-design? And I'll start off by having you look at this beautiful picture of a door. And I want you to just imagine with me for a moment that you're going to a meeting, and you're going to a meeting in person, and you're maybe running a few minutes late, you're walking really quickly, you come up to this door, and then what do you do? Can someone shout it out? What do you do if you come to this door?
Well, I will pull the handle, right, toward me so the door
Okay.
opens.
I'm gonna grab the handle and I'm gonna pull it, but it's locked. And I'm like, oh, I'm pretty sure this is the right room. So you look at your phone and you're trying to figure out okay, I'm in the right room. So you grab the handle again and you pull it, and it's definitely locked. And just as you're about to call the person who you're supposed to have a meeting with, the door opens and you realize, oh, the door wasn't locked. The door opened from the inside and you had to push it rather than pull it. And you're feeling a little bit silly now, but you shouldn't, because this door is literally designed for you to fail. And I provide this example because I think it's the most simplistic example of like why it's so important to design with people that know about the context, and it's an oversimplified example in this case, right? Because co-design is usually about something more complex. But if you had brought together people to this design process, you would have quickly learned that when you want to push something, you would provide a flat surface for pushing, right? And you don't necessarily need co-design here. You could use other design techniques, but it's just a way to understand like why it's so important to design with people. So I want to provide some examples, and I hope it's okay that I just ask you to shout it out. But let's take an example of a person who has many multiplications, many medications, and they're trying to manage all those medications at home. What's a tool that you might use to support them in managing their medications if they had polypharmacy, like several medications that they're taking daily? Maybe some of you have used this at home.
Please unmute
Might
and
get a pill sorter or a pill box.
Yes, something like this,
Kinda.
right? Like the pill box. Yeah, great. So this is a really common solution that's used for people at home to try to help them organize and keep their medications on track. And I've done a lot of work where I've gone into people's homes and just really tried to understand how they manage their medications. And I quickly realized that solutions that might work for one person, like a pill box, might not work for other people, and that people create their own systems at home. And even though these pictures look cluttered or disorganized, they actually have created systems that work for them to manage these medications. So in the picture on the left, all the medications for the family are mixed together, and they keep them in certain places for certain reasons, because they get cued to take them at those times. And similarly, on the picture on the right, the medication bottles are placed in a way that's meaningful to the person. And if we were to design for these folks, we might have to think about different solutions than the pill organizer that we saw in the previous picture.
Nicole, I will just, so that you are in for the fun, Russ asked, how did you get a photo of his desk?
Yeah, I feel you. I have the same problem. Okay, and then how would you design a medical device for tube feeding at home? And you don't necessarily have to answer this question. I just want to kind of show you this picture, is that when children go home with with tube feeding, they're often on feeds, especially small children with medical complexity are on feeds that are 24-hour continuous feeds. And it's not, these devices are not designed for there to be movement or sleeping or leaving the house. And so they get these tube feeding enteral pumps, which is the kind of this blue box here. And what this parent did was they attached it to a mop handle, and then they put a carabiner on the top of the mop handle so that they could take their child in the car while they were getting their feed. And otherwise, they would have had to like tried to position it while they were driving, and it was the tube would get clogged and all these things would happen. And so this was the solution that the family had to come up with, because they were not involved in the design, and their situations weren't considered in the design of this product. And so these are just some examples, many more examples than this, but just wanted to provide you some illustration of like why it's so important to involve people in the design process. And then the other question to answer is when? When do we co-design? And my answer would be at the beginning. And so this is just a visual depiction of the NIH stage model for behavioral intervention development. It doesn't have to be a behavioral intervention necessarily, but that just tends to be what I work on the most. And in the NIH stage model, you start at stage 0 with the evidence-based foundation, then you go to design and feasibility test, your efficacy trial, and then effectiveness, implementation, and dissemination, right? And I think I don't need to tell all of you that that's problematic. That doesn't happen until stage 5, where we think about dissemination and implementation. But when we're thinking about co-design, I think that we really need to start at the source, right, at that stage 0. And stage 0 is when we're creating the evidence-based foundation. And that's where we're deciding like what are the problems that need to be solved, what are the research questions that need to be asked. And I think in the case of co-design, you bring I call them end users for lack of a better term, but end users or co-designers or people that will be affected by this tool or process into this evidence-based foundation, so that you're solving the right problems. You're creating a solution that people want and need. You're considering the context and lived experience from the start, and really even thinking about like what outcomes actually matter here. And that way, you're not falling into some of the traps that I've fallen into, which is solving for the wrong problem. Not creating something where there isn't really a demand, and maybe creating kind of the wrong solution for a problem that's really challenging for people. And so if you start at the source, you reduce your potential for doing that. And I've definitely fallen into these traps and waited too long and started at the kind of later down in the pipeline. And I think you'll hear me later on talk about, I'm really into this idea of moving toward co-design. So I don't think it's possible to go from, where I was doing experiments in a psychology basement to like the next day being, completely focused on co-design and implementing it in all the right ways. It's just not possible. It's really a process to get there. And then, of course, the big question is, well, how to co-design? And this is actually, I would say, a work in progress and an area that I'm really interested in from a research perspective is how do we continue to improve methods for co-design? How do we measure those methods, like the process part of it, and keep improving? And so I've been doing this for a handful of years now, and I keep trying to move forward my approaches. And I think of co-design as really being an iterative approach. And so I have these pictures on the screen here because in the top left corner is kind of like the initial generation of ideas going through this kind of sketched out prototyping, and then finally into like a wireframe or more high fidelity version of the prototype that's going to be created. And so this is an actual project that we engaged families caring for children with medical complexity, and they designed this tool that we just finished a RCT on recently. So the protocol that we've developed over time has become this 5-stage approach for co-design. And so the first stage is problem identification, where we bring folks together and we work with them to identify the problem. That stage can be quite extended or it can be short. It really depends on the scope of the problem. But it can start with, things like interviews and focus groups, right? So I just want to point out here that there's like a place for doing interviews and focus groups within co-design, right? It can be, there can be different approaches as long as you're kind of including that democratization piece in that process. And so we often have people with lived experience as members of our research team so that we can make sure that we're kind of asking the right questions and providing that shared decision making, ensuring that shared decision making is happening across all the potential end users. Once you've identified the kind of problem to be solved for, then you move into stage 2, which is solution generation. And this is where you're just like big sky, lots of different fun activities that can be done here. And there's lots of great books, and I can actually send you all like a list of resources, but there's lots of great books that have good activities for co-design and things like that. So I'm not going to get into that because each of these stages also has like many different potential activities and co-design and engagement activities. But there are people who have done much better work in that space than I have. So I just kind of leverage those resources for the solution generation. Then once you have all the ideas, you have to come into some kind of convergence process so that you can figure out, okay, for this design process, where are we going to go? How are we going to focus? And then you move into prototyping where you're actually creating that thing. And then finally, you're doing some initial evaluation before you move the prototype forward. And I just want to also point out here that we've used this process for many different things, right? It can be an actual tool. It can be a toolkit, like an implementation toolkit. It can be a process. You can co-design a process. You can co-design a set of strategies. So you can co-design lots of different things in this design funnel. It means like, for example, your prototyping process is going to look a little bit different. When you're creating a toolkit that's kind of more of a PDF versus a whole mobile app, there's like a different level of process involved with that. So these are just the general stages, and then they can kind of expand and contract as needed depending on what's being co-designed. Within each of these stages, or within each co-design session that happens within the stages, I tend to use a 3-step. And there's a paper on this that's not cited, so I'm sorry, that should be there. But I can send you that. But essentially, you start with priming, which gets people to think about their own experience in relation to the design work. So a lot of times we have people like do pre-priming activities. So we'll give them like a journaling exercise, or we'll ask them some questions, or we'll ask them to look at some data and kind of provide some reflection on the data. And that gets them kind of ready for whatever design activity we're going to be doing in that day. One of the biggest things I've learned over time is really getting people prepared and setting expectations for what's going to happen in the design session. And that is where success increases and the meaningful experience of engagement increases. And so that's been something that we've been working on over time and that I've been learning from feedback. We ask for feedback after each session. So this priming becomes more and more and more important the importance of it has been clearer and clearer to me over time. Then we get into the design activity. Again, there's lots of different activities you can use, and you have to kind of choose the right one for your specific goal at that time. We do a lot of like ratings and rankings to spur discussion. We do some where we ask them to create like storyboards for a commercial for a product they created to solve the solution or to solve the problem. We have people tell stories. So we do lots of different things. There's many different activities that can happen, and you can think of them as kind of probing, generative, or evaluative. So there's different goals you might have, and then you pick the activities to do that. And then finally, debriefing, which is where you can kind of reflect on what happened in the process, either at the individual or group level. And then I usually like to also just ask people for feedback and give them an opportunity to say anything or contribute anything that they didn't get to in the session using kind of like a feedback form. Because I think I want to give people the space, especially if they are people who aren't coming up with ideas as quickly as others and things like that. So giving them that space to contribute later. I'm going to give you an example of how this plays out in a couple of projects. One is this financial and legal planner. It's an AI-based financial and legal planner for caregivers of people living with dementia. So we took two groups of caregivers through these 5 stages from problem identification, where we had them do journaling, and then we introduced the project with an explainer video to kind of let them know like where we were at with the project. And then we had them kind of share their journaling activity and voting together on what was the most important topics for financial and legal planning that we wanted to include in our the most important challenges, financial and legal planning challenge topics that we wanted to address in our solution, then bringing them through the solution generation with storyboarding, where they would actually sketch out what they were doing, what would happen if they were using the tool, convergence, where we were bringing kind of a clickable prototype to kind of narrow down the options of what the prototype would ultimately be, going through the prototyping process again, where they're sketching and we're creating the wireframe, and debriefing and evaluation. So doing a walk through the prototype, having them think aloud with the prototype, and then completing an assessment using the system usability scale with open-ended feedback so that we could use all of that to ultimately improve the design. And so this is the initial prototype that they created. It's actually, we just finished a 90-day field test of the final version of this. They created this tool that caregivers were able to actually use. And it was an SBIR, so hopefully it will be out there and available to people, to caregivers. But the process, I'll come back to in a minute, was not what we had expected at all. So we really had to go where the caregivers took us on this one. There's also like different structures we use, and I just want to kind of give a couple of examples just quickly, so you can kind of get the scope of how we're thinking about using co-design. There's me with longer hair. So this was a while ago. This was for our patient safety learning lab intervention, where we created what we called an intervention implementation team. And the idea was that we wanted to be thinking about designing an implementation process with our intervention, so having them kind of be one and the same. And this was for managing antibiotic stewardship for older adults from the emergency department to the skilled nursing facility. And so we brought together a group of kind of different partners, emergency medicine physicians, people from the skilled nursing facility, Epic people because we were going to implement this in the electronic health record. Lots of different perspectives, and human factors engineers, of course. And we had several core meetings of the intervention implementation team, but then we also did a lot between the meetings. And I think that's something else that's an important point here, is that often when co-design is happening, there's lots of different groups that are meeting kind of in parallel, and part of the design process is kind of integrating over time, but making sure you're always bringing back to the co-designers, the core co-designers, the ideas that come from the other teams, so they can kind of be the ultimate decision makers around what's happening with the prototype. And then this is just the intervention we created was completely in the electronic health record, where we were able to kind of automate communication so that the SNF providers could actually get information about patients that were seen in the emergency department, which sounds like something that should actually happen, but it didn't go to the right person, turns out. So that was how we kind of got that implementation going. And then the third example, the final example, is just we co-designed a toolkit for healthcare systems to do to improve inclusion of caregivers of people living with dementia in hospital care. And so this is really kind of like processes, like how do you implement a program to do this? And we had a separate group of care partners and a separate group of clinicians who care for people with dementia, and did this in parallel and kept swapping the design ideas back and forth to ultimately come up with a toolkit. And I'm not showing the toolkit because it's a PDF and it's hard to show on the screen, but the ideas they came up with, there's these 3 phases of hospitalization, and within each of those phases, there's specific objectives that need to be achieved. And that's what really was the foundation of the design, the ultimate design of the toolkit. And this was co-created from both the clinicians and care partners, and they were able to come into alignment kind of separately through our facilitation on these objectives, which is harder than one might think. Okay, and then finally, I just want to talk a little bit about this idea of moving toward co-design, because I think it's something we can all do if there's interest and motivation. And so some of the things that we're thinking about as our group is moving toward co-design are just some of these challenges with how do you do this well, and questions that remain unanswered in some of these ways, and also very dependent on the situation and the goal of the co-design. So some of this comes with group formation, like how many people to have in a group, and how do you break out the group in different meaningful ways? Is it 50 people? Is it 5 people? How many perspectives do you need to have? And that's been an interesting challenge that we've had, like question that we've had for each project, and then who to include in the co-design, because sometimes when you think like we do, where it's like, who are the end users, it becomes this enormous group. And so some of the way we've been handling that is in some of the examples I showed you, like we'll have different groups of different types of partners, and then maybe we'll include like an advisory board that gives us input at certain points, but not throughout the whole process. And so we've tried to think about input at different levels and who's really the core user group, and then how do we bring in other perspectives. And then an interesting one I mentioned kind of in passing is this in-person or virtual. Is really a challenge, because there's in-person is just more fun. Typically, you get to like cut up things and draw, and you're with each other, and it's easier to get the ideas bouncing off. And but for the past several years, we've been doing these remotely for the most part, and really trying to engage new strategies for like how do we get people to like really engaged in this process virtually. And that's been fun. And so we've been sending people kits as one strategy, like design kits, where we give them like templates and things so they can do some of this cutting out and sketching while they're at home, and then we share it. So really trying to get people engaged in that way. But that's something that we're really still exploring and trying to push forward. And then this other idea of like how to configure and engage the full team. So I think some of what we've been realizing is what are the individual needs for engagement, and how do we identify different individual preferences, and comfort with certain activities, and then have a suite of activities we can kind of map to those individual needs. Some of the lessons that we're learning, one is not coming with a solution framework. It is really hard to do this. It's really hard, especially how, you know, we're taught to be scientists. It's really hard to come with an open mind about what the solution is going to be. I'm not good at this. And so I've often come with a solution and then been told, no, we're not doing that. And then having to like be flexible that, okay, okay, I'll listen to you. And we're going to go this direction. I mentioned before preparing people for engagement. So how do you really make sure that people understand what you're going to be asking of them, that they're prepared, that they have the full scope of what's going to happen, and that's going to make it so much more meaningful for their engagement. It's going to make the engagement more successful. Confirming time and commitment. So this is really about not making assumptions. So I had assumed that because I was working with caregivers that they wanted a shorter time period because they were already being asked to do so much and I didn't want to ask them to do more. And then over and over again, I kept getting the feedback like, I wish we had more time. I wish we had more time. And this has happened now across sessions. So I've now learned my lesson. It just took me a while. But just, you know, I tend to make a lot of assumptions without, again, asking people, which is really antithetical to co-design. So trying to remember that it's important to like allow co-designers to co-design the process as well. I noted the idea of like, how do we think about meaningful engagement from an individual perspective rather than the co-design group? I had someone send feedback once that was like, I will never draw for anyone after I had asked people to do a drawing activity. And I was like, oh, I really missed the mark there. I should have really tried to understand what everybody's comfort with and not just require everyone to draw, but give alternatives, right, to the activity. And then I have this idea of some feedback we've gotten on like, how do we actually measure what matters in co-design? And I talked about this a little bit in my last slide, but we got a lot of feedback just from, especially with the population that we're working with, that like just being in the co-design makes me feel less alone, just like being part of this process. And then a lot of feedback about the importance of the feedback loop. They want to know what's going to happen next with the thing that you've created. They want to know if it was successful. They want to hear more about it. So making sure that there's that sustained engagement piece of the feedback loop. And then specific to democratizing, which is also really challenging, we come from, right, where most of us probably on this call, NIH-funded researchers, PCORI-funded researchers, projects are top down, right? Like if you look at the nature of our funding structures, it's really like go to the science and the scientific premise. And I still believe that's extremely important. I'm not saying it's not, but it makes it really hard to do true co-design in some ways. And then this idea of going where the co-design takes you, I mentioned before about the flexibility where I've come in, I've written a grant and I've said in the grant, we're going to do this thing. And then the co-designers say, we don't want to do that. Specifically the planner that you saw, they really want to just tell us how to get things done. We don't want like your education. We don't want more training. Just tell us the steps we need to do to get it done and help us get it done. And then kind of interesting and unexpected is this idea about what is the role of the research team, right? We're all supposed to be co-designing together, but we often just say like we're facilitating the co-design. And I think that's actually a mistake that we've made, where we should be kind of working together, and the co-design really requires different viewpoints and different experiences. And so one of the researchers that was interviewed in this cited article that we did that kind of reflected on four studies, co-design studies, is if I was getting involved, I would have felt like I was taking space away from the co-designer. So how do we create a method and an approach that allows everyone to contribute? That's really important. And just these challenges with sustained engagement. You lose funding, the grant ends, and like how do you keep engagement going? Finally, just really want to highlight the importance of how do we know we're doing co-design well? And I don't think we have great robust measures for that yet, or an understanding of how to do that, especially around these individual needs piece that I mentioned before. I'm really interested in like what activities and the co-design strategies lead to better outcomes, both for the people in the co-design process, but also for the product of the co-design, and what outcomes matter most to those that are part of the co-design process, both the research team and the other partners that are part of the process, and really trying to tease out what those outcomes are so that we can measure them and see that we're actually improving those outcomes. Oops. So I didn't talk a lot specifically about my career goal to transform the patient journey, but this is the process of co-design that I'm trying to use more and more and advance more and more to transform the patient journey through that co-design process. And I thank you again for letting me be here today. I'd love to hear your questions.
Thank you so much, Nicole. Such a great presentation and so many questions in the chat. So I will pull in a few if you want to browse them for a moment while others are also formulating questions. We have about 10 minutes. So I'm going to start with one of them just to orient you. I think it's hard to get through everything. And then we can also open it up for more comments as time allows. But the first one I will bring forward is from Monica, and she was asking about you expanding on converging all of the ideas stage 3, especially if there are many from partners. How do you do that?
Yeah, this is definitely challenging. And I think there are different ways depending on the group. But a lot of what we do is we have the co-designers doing that, right? And so I think we bring them through a process, through discussion, through activities to really focus on what is, how we're going to converge. And so part of that is like identifying with them, what are the boundaries going to be here, right? We went like big blue sky, but in reality, like how much money do we have? How much time do we have? What do you think, so we'll do like, often do like one of those matrices with the, like, what's the, most feasible and high impact, what's the least feasible and least impact based on what they decided were the criteria. And then they will do the matrix there. And then that's often how we'll kind of take people through that process. Sometimes it's really obvious, like, oh, you said you wanted to create a mobile app that's going to, talk with your primary care physician every day. Well, we can't do that. But this other idea here, like we can probably do that. And so sometimes it's like really obvious, and then sometimes it's a really long process of identifying what are all the criteria that were going to be our boundaries, and then how do we put them on this matrix, and then okay, now there's 6 things in high feasibility, high impact. So like let's take these 6 and now let's do that process again. And so that's typically how we do that. And then you mentioned when there's lots of other viewpoints. And so if we don't have everyone in the process with that needs to have viewpoints, we'll do it in stages. So a recent process we did like that 4 times that feed and then we brought kind of the results to the core co-design group, as we call them. So we try to always pick a group who's like, you're going to have the final decision here. And so we try to, and it's usually the people who are like ultimately going to be the main user of the tool. So like, for example, if we're working with families of kids with medical complexity, they're going to be using this in the home. We've like, in the health system, we've like created them as this autonomous healthcare team. And so we're like trying to respect their role in that way. But we do bring clinician input in, and we make sure that the things that are being created have like a clinical eye, right, are clinically relevant and safe and all of that thing. So then we bring it back, those comments from the clinicians, to the families and integrate them in that way.
Thank you so much. Yeah, of such complexity once you bring in multiple perspective, but not a negotiable component. Mustafa was asking about motivation for co-design, especially for participants. Could you speak to that?
Yeah, like how we motivate people to do co-design.
Yes.
I feel like I have not had a problem with motivating people to get involved with co-design. So maybe can you tell me a little bit, is it allowed? Can you tell me what you're thinking?
So I think what I was thinking is, you have a limited time, and then you bring people, and then you want them to be as efficient as much as possible, so that how do you make sure, that you get most out of them as much as possible?
We do a lot of planning. So I would say that co-design is extremely resource intensive, if I'm being honest. We do a lot of pre-meeting planning with our smaller team to create the right activities, to create in particular the priming activity that gets people kind of prepared and ready for the co-design session. And so I think that is really what we do to try to make it most effective, is get them extremely prepared as we can. There are different levels of like how much people will do before a session. Like caregivers will do a ton, clinicians not as much, which, makes sense given the kind of work structure. And so, but we try to get people as prepared as we can and then have activities that are specifically designed ahead of time to get what we want out of the session. So if we know we only have an hour, like when we were doing the toolkit, the dementia toolkit for inclusion of care partners and hospitalizations, it was like we knew the clinicians had an hour and that we were going to get an hour out of them. And they probably weren't going to do a lot of the primary activities. And so we just tried to really design the sessions so that we were like, okay, here are the 3 things we need from this session, and we're going to, get there.
So very focused, very helpful. Thank you so much. Noe was asking about sustained funding for co-designing projects. How do you think about that?
I don't think that exists like in the NIH world, or in the PCORI world, really, or in any funding world. Maybe if you had like a cool donor. I think what I've had to do is just like maintain relationships outside of funding. And then I try to kind of also keep people informed about what's happening. So I wish I had like an answer that was, oh, there's this funding mechanism that does X, but it's really doing stuff outside of funding. And it does take a lot to maintain those relationships. I think if the question is also like, how have I kept bringing in funding for co-design? I try to put co-design in everything I do. And so rare is it that I write a grant that doesn't have some aspect of co-design in it so that I can keep maintaining and advancing the co-design process. And then what we do is like use that data to, or use that project to study something related to the co-design process, but it might not be a project specifically about co-design. So we kind of sneak it in.
Nicole, this is Russ. If I could just quickly follow up on that or turn it to the early stage, wondering about your experience with getting a grant reviewed or funded, where you don't come in with every detail of here's my intervention.
Oh, yes.
Say, here's the
That's a great
process
question.
that I'm going to use over that. Have you had trouble with pushback on that, or what strategies or recommendations would you have for that?
Yeah, that is such an important question. Thanks. I should bring that into my talk actually, because it's so critical. So I've had a lot of K mentees who use co-design. They do like co-design and then the pilot trial, which is like a big leap, right? And so it is a challenge. And so what we've done is kind of maybe gone out of, we're saying we're doing co-design, but we're kind of taking ourselves out of the real co-design process, because we're saying we're probably going to design these minimum aspects. Right. So we say like there's some minimum requirements for this process or this tool that we know are going to be part of this because of the research, right? The literature. And so we say that boom, boom, boom. And I say, but the co-designers will also do these things. And so that's how we've the strategy that we've created to get around that. Because it does come up in review a lot. How are you going to do a trial for something you haven't even designed yet, right? So we've tried to get around in that way. But it does take us away from co-design, true co-design, unfortunately.
Thank you so much. I am looking at time, and unfortunately we are running out of it. So we'll encourage, if appropriate, Nicole, for people to reach out to you. I don't want to put more on you.
Yeah, absolutely. I can,
And so we will be sharing the recording, we will be sharing the slides. Kara will post those and we'll reach out to Nicole to obtain those. Thank you so much, Nicole, for providing as well your email address.
Yeah,
So
let me put it in because I had a
you are
typo.
welcome. Yeah, we are welcome to reach out. But this was so wonderful. And certainly when we think about adaptations, fidelity, and tailoring, co-design is one of the ways that we are trying to get around and even perhaps avoid adaptation by creating something that is for a given setting. And so this was very timely and very helpful.
Okay, good. I hope it was helpful and happy to answer any questions. Really, please do reach out. Thanks.
Thank you so much. Thank you for coming, and bye everyone. See you next month.